Hi everyone, and welcome back to the Chemist Couple podcast with your hosts Lee and Jess. We are both clinical pharmacists who work in GP practices in the northwest of England, and the aim of our podcast is to provide evidence-based advice, personal experiences and create awareness around long-term health conditions. We hope you enjoy the show.
So hi everyone, and this week, as we discussed last week, we're going to be discussing the treatment of type 2 diabetes. It's a very, very big topic, so we're going to try and navigate through it best as we can. We will probably miss out for some things because, like I say, it's just so big, but we're going to give it a go.
Yeah, you could do a whole podcast series on management in its own right.
Yeah.
So do you want to start?
Yeah, so the first line treatment, as for most long-term health conditions, is diet and lifestyle. So whenever you are diagnosed with type 2 diabetes, you will have targets of what we would set for your HbA1c. So we discussed HbA1c last time, we're not going to go into it now. But for anybody who is newly diagnosed, usually your HbA1c will just be above 48 is what we hope. And so that means that you're just in the diabetic range. So lifestyle modification is the first line. So at the moment, there is an NHS structured education that's available. So it's called Desmond, and any patient can refer themselves to it. So if you are newly diagnosed with type 2 diabetes or know someone who has been and haven't been for or signposted to this, then it's worth just maybe giving your GP a call, because you actually can be put onto Desmond if you've been newly diagnosed or if you have actually ongoing type 2 diabetes. And it basically offers some education around the condition. There's also support groups, so I think that's a big thing in terms of any long-term health condition. Having the support of other people who are going through it is only a good thing. Yeah. So you'll be put in touch with other people living with the condition, and then they'll give you education on the diet, lifestyle, and medications as well.
Yeah, so we'll go into lifestyle from our point of view and what we've read. So last week we did say that type 2 diabetes isn't a life sentence. It is something that we can now induce into remission. There's been theories out there since 2008 called the twin cycle theory, where it's basically fat accumulation within liver and pancreas, and it just alters how your body uses insulin, produces it, etc. Mm-hmm. Now, the basis of this recommendation comes from a direct trial. That's the name of the study. And it's been prolonged to 5 years, the evidence. Yep. And basically it showed that at this point you can still maintain remission provided you do have weight loss at this point. And the whole study was against an intervention group where they had a weight management program, for example, against a control group. So it was reasonably applicable.
Well conducted.
And like all studies, I think this one was a BMI of 27 plus. The diagnosis of diabetes was within 6 years. So it doesn't apply to everyone. You could have had an acute diagnosis, it could be prolonged, you could have had a lower BMI, etc. So everything needs to be taken with a pinch of salt in studies. But the lengths that it went to, the extremities, was calorie restriction to 850 calories a day through meal replacements.
Which is quite low.
It's very low.
That,
because the average adult, well, female, it's meant to be 2,000 calories a day. Male, you get a bit more leniency because you're meant to have greater mass for the same body volume, etc. So 830 calories is, well, greatly deprived, isn't it?
Yeah. And it's like a meal replacement, isn't it, that they basically get, so you wouldn't have to be cooking 850 calories, which would be quite difficult, to portion control and things. You actually are given, or they were given, a meal replacement. Yeah,
and it did lead to significant weight loss. It was like 15 kilos in the study groups, and then at 5 years, the average weight loss was about 5.6 kilos for the intervention against 4.6 for the control group. Now, I'm just going to go through the exact stats, which show that the intervention group had a 10% rate of remission still at 5 years in comparison to the 5% in the control group. And there was another study that it was called the Look Ahead trial, and it showed that if you were at any point in remission throughout your life within diabetes, it has some sort of beneficial outcome, whether it's reducing cardiovascular disease, kidney disease, etc. So in the intervention group, 27% of the time for the participants was spent in remission in comparison to 4% in the control group. So just even by intervening, they have had some benefit with being in lower blood glucose concentrations, etc.
Mm-hmm. And the only thing I was going to say with regards to like just in lifestyle and what we advocate for at the moment is, as health professionals, we're not very good at it. And if you look at like the amount of training that we get or teaching that we get, you know, doctors, nurses, pharmacists and other allied health professionals, when we're actually at university, it's really not a lot on nutrition. And considering that, like I just said at the beginning, a lot of long-term health conditions are a subsequent, what am I trying to say, are a result of, they result from poor diet. It is, you know, it's baffling that we don't get taught a lot more. So, you know, all of these trials are going on, and hopefully over the, you know, coming years, we will start to adopt more and more of the research that's going on. But I think at the moment, we are still pretty bad at, you know, at deciphering what we should be advocating for our patients.
But we've touched upon it many times. It's easier to give a tablet, a regime that's a quick fix, and because if you actually look at type 2 diabetes, insulin resistance is meant to precede the actual diagnosis by 10 to 15 years. Yeah. So you are intervening from a point when you actually haven't got any disease. And like we said numerous times, that it's not appealing for people to prevent something that might never come about.
I know, unfortunately.
But going back to why I brought this whole thing up is that it does prove, like we've just said, lifestyle is a big influential factor. A lot of medication, etc., is based upon plants and food sources. We have receptors that work upon these things. So it's only right that food is medicine. Yeah. And it's hard to get your head around. Even doing the degree that we've done, I said to you the other day, I never thought about food in the same way I think about it now. Yeah.
I think when I was at university, there was a course that you could take, and it was called Food as Medicine, which probably would have been quite interesting to be able to take, but I didn't end up.
I mean, when you do medicinal chemistry as a part of the unit, it does go through the structures and how these interlock and intervene with the body.
Yeah, and like you say, in terms of nutrition, this is something that we're doing every single day. So, you know, if someone's taking, say, for instance, a medication, if they're not compliant with it, they're not going to be taking it every single day. So, and it may be just once a day, whereas you're eating and putting things into your body which are interacting with your body 2-3 times a day, even more, you know, if you're having snacks and things. So that's why it is so important to get nutrition right.
Yeah. And one thing I want to point out with this is we did say it's 830 to 850 calories a day. It was about 12 weeks.
Yeah.
And then they are coming from meal replacements. So again, that's an ultra-processed food a lot of the time. Mm-hmm. So we don't know the benefits of having a calorie-restricted diet with whole foods, for example. I'd assume it to be a lot better because it's more nutritionally dense.
Because we will go on to that, won't we?
We will go on to that. But also with nutritional studies, a lot of it's reliant upon you filling in a food diary. If I asked you what you had to eat yesterday, could you recall everything to the exact quantity?
Yeah, no, it's very difficult.
And then, especially when people are in denial, a lot of patients who are sadly to the upper limit of the BMI and diagnosed with these multiple comorbidities are more likely to, not publicise what they are taking or eating. Yeah. So that's why these studies are quite hard to come about. And when you do get something like this, that's why originally it was for 2 years, and then it was funded to go for an extra 3, just to see if it did have any substance and whether diabetes is more than raised blood sugar.
Yeah. So actually, as part of the NHS long-term plan, this study, I think it is involved in that. So patients are being put onto these low-calorie diets. Also in the NHS long-term plan is to get more nutrition study, teaching studies within medical schools. So hopefully, like we say, in the next 10-15 years, we will see a change in terms of trying to prevent diseases rather than just treat them when like a patient presents with it.
Yeah, I mean, when I've looked through the management for this podcast, the guidelines have actually changed for nutritional advice and information. Oh, okay. So normally it's low sugar, low fat, etc., etc. Yeah. But now it was saying to incorporate like pulses and whole foods. Okay. It has actually changed a bit, and that's only been within the last couple of months.
Yeah, it will.
Because I did look at it beforehand.
Yeah, because actually when we started this podcast back in January, one of the first things we looked at was all to do with that, and that was simply because of people who've been following us since the beginning. Lee had and like a little bit of ill health, didn't you? And you were diagnosed with Modi diabetes as an adolescent. So we were really looking into how can we improve your HbA1c, and so we would have looked at them guidelines to see, well, what are we actually telling our patients at the moment? So yeah, it must have been only recently that it has changed. Because you were actually having a low sugar, low fat diet
and
prior to us starting the podcast and you getting ill. And since then, we now have more fat than we ever have, but it's the right fat. We don't really think about calories. We don't really think about, getting too much protein in. It's just eating, whole foods, isn't it? And nourishing our body by eating the rainbow.
Yeah.
And you've seen a massive improvement in your bloods.
Well, we have, haven't we?
Mm-hmm.
But in terms of going forward with diet and lifestyle, do we want to touch upon ultra-processed foods?
Yeah, so I think ultra-processed food is obviously something that we need to touch upon. And that is just simply because in the UK, we eat a lot of ultra-processed foods. So we've mentioned it in the past. There's a regime called Zoe, who Professor Tim Spector is one of the founders of it, and they've been looking into ultra-processed foods and how it can affect different things, and they've also looked at how it can affect type 2 diabetes. So they've done some studies on it, so let me just get the study up. So the study was published in the Lancet. It was actually around about 311,000 people in the study, so that was quite a lot of people.
Yeah.
And it was conducted all across Europe. I think there was 8 countries in total. Everybody in the study at the beginning didn't have type 2 diabetes, so the end point and what they were measuring was how many people at the end of the 10 years, which was a long time, had then developed type 2 diabetes. Of all of the European countries that they tested as well, the UK was having the most amount of ultra-processed foods. I think it was like 57% back then, but is it slightly higher now, or is it about the same?
Well, we outdo the French and the Italians by give or take 4 times.
Yeah. It's
only the leaderboard that we're actually winning it.
Yeah,
the wrong way.
It's weird, isn't it? I think we looked at it in a previous podcast as the reasons why, and it's more like it's like socially, isn't it? Like if you think about people in France or Italy, like they tend to eat like with family and at the table and cook foods. Like it's a whole cultural thing, isn't it?
Of course it is.
Whereas in the UK, sadly, we've kind of lost a bit of that, haven't we?
Yeah.
But anyway, the study found that consuming ultra-processed food did increase your likelihood of developing type 2 diabetes. And interestingly, they also found that, we categorise ultra-processed foods by the NOVA classification, which is a new classification system that's recent. I don't know when it came out, was it about 5 years ago, something like that? It's recent anyway. So during the actual trial of this study that they did, the NOVA classification system wasn't about.
Okay.
But when they've reviewed it and they've looked at how they classified the foods at the time, eating foods within the NOVA classification 1 to 3, which means less processed or even non-processed. So that would be things like vegetables, fruit, they'd be classed as like non-processed. Then you'll get things like milk, which is minimally processed. So they're all things that what you would consider to be healthy.
Yeah.
If you eat more of those foods, it actually protected you from type 2 diabetes. So it just kind of shows that your food is very influential. It's not just that ultra-processed foods can cause it, it's actually that eating the correct foods can actually reverse it as well. But in the study anyway, 4.6% of people developed type 2 diabetes, and there was a strong link with the amount of ultra-processed foods. Ultra-processed foods just generally contain a lot of sugar, sodium,
and it's the way that they're formulated as well, that your body doesn't sort of recognise it as quick as it would with the whole food, because you've got to break it down, you've got to chew it, etc. So it takes longer. So by that point, your body's got the right hormones in place.
Yeah.
And that study that we have talked about before, I think on average you eat 25% more in the same composition if you had no sort of limit on it than if you were to have a whole food diet.
Yeah.
So that could all contribute to type 2 diabetes, because as we've established, it's excess storage of fat within the wrong places.
Interestingly though as well, what I just wanted to finish off with this ultra-processed food, and with all of this, there is more studies and more research that needs to be carried out, because it's a very new science that's emerging in terms of like the gut microbiome, ultra-processed foods. Like we didn't even really understand ultra-processed foods 5 years ago. It's very new that it's all come about this. But in that study, it actually was showing that it even depends on the type of ultra-processed foods you're eating, which can increase or decrease your risk. So if you were having things like animal products, so when I say ultra processed, it could be things like bacon. So they're ultra processed things which they've got added things into them to bulk them out, you know, so a lot of sugar and salt. They increase your risk more than an alcoholic drink did. So alcoholic drinks show that there was no increased risk, which, I mean, I would take that with a pinch of salt. Obviously,
what type of alcoholic drink was it?
Well, it didn't actually say, but also alcoholic drinks, you know, the bad for you in other ways. We also know that obviously they're processed through the liver, and so, you know, that could but anyway, in the study it did show that there was different types of ultra processed foods which carried different risks.
Yeah, I mean, going back to diet as well as a general term, so we advise the Mediterranean diet as a gold standard in healthcare, the NHS, and it's high fats, not as much protein as you think, it's more legumes, etc. And veg, but there's been a link obviously with lower risk of type 2 diabetes with the Mediterranean diet, but because you can't exclusively single out the Mediterranean diet, it's all the lifestyle with it. So the Mediterranean lifestyle is more active, there's more sunlight, there's probably less social and work pressures in certain environments, so you can't single out the actual diet as being the sole beneficiary factor.
No, of course.
If that makes sense.
Yeah, no, yeah.
But one thing I wanted to say too is I've been speaking to a couple of family members about diet and exercise, which we'll touch upon exercise in a minute, but it's to not have this negative relationship, and it's all the cyclical process of we've got 4 weeks before an event, let's do this, we've got X amount of time before this, and it's this idea that you should just walk before you run. And this family member was saying, oh, well, I can't go and eat there now because I can't have this, I can't have that, and it's not food as a culture.
It is. I think that it's really important to get across to, but I think we live in a society where it's all or nothing all of the time. So it's either you're in or you're out, and it's not like, well, actually just take it slowly, build up to it. You know, whenever we did it, so obviously we now eat a whole food diet, it was a gradual thing. It wasn't just like one day we'd gone from eating takeaways and, you know, drinking fizzy drinks. Not that we've ever really done that anyway, but, you know, we didn't go from that to then just literally cutting it all out, because it's not sustainable. So it is about just taking baby steps, and you'll find that whenever you do transition over and you do start eating all these foods, they're so much more tasty. Like, they've got like the flavor profile of different spices is, you know, and your taste buds will start to get used to it, and you'll be like, why did I ever not eat it in the first place? But ultra processed foods, obviously they give you a lot of salt and a lot of sugar, so it is immediately in your mouth, and your brain thinks, you know, oh, this is really good, and actually when you strip it back and you stop having it, it's revolutionary, to be fair, I think.
But a lot of Asian food, for example, has a lot of salt, yet they don't tend to have the same rates of blood pressure that we do. Because, like, there's all certain foods, there's a soy, miso, that have this natural profile of salt, where we add salt to absolutely everything in England anyway. I know. But it's just this idea that we have developed this culture, and it helps regulate your body as well. That's the hardest thing. So we move away from calorie counting. That's not something I've ever done. You were more about it when I first met you about 5-6 years ago. But now you've come away from it, you actually don't look at any numbers in terms of what energy is going into your body, because you've got to a point now where you just know. Yeah. And when someone gets to the top of the game in anything and they say, oh, well, you'll know when the right time is, it's the same with your diet and exercise. You'll just know, your body will communicate, it knows what it wants. And that's the hardest thing to get across, especially when you've got diet controlled types of study in terms of 830 calories a day. How do you go from that to then advise someone on a whole food diet?
Yeah, no, it is.
That's what I find difficult. But if you were to take anything home from this, increase the amount of vegetables and plants and mushrooms, etc., that you do eat within your daily lifestyle, because you will improve all aspects of your life. I don't think there's no benefit from it. Obviously, when you improve vegetables, there are medication that could interfere with it, so like morphine, for example, but you would seek, I think you just go for a general review before you started changing your lifestyle drastically. Yeah,
but apart from that, there isn't really any other things I could think of. The only other thing I would say is that with diet, obviously everybody's individual, and so, you know, whenever we are advocating as health professionals for diet modification or lifestyle modification, we should be thinking about the person that's sitting in front of us, not generalising everybody in the population, because, like I say, everyone's different. also during this Zoe studies, so it's like the biggest, I think, study that's going on in like nutrition in the country, or potentially in the world actually at the moment.
Sure.
It shows that everybody reacts differently to different foods. So like one person may have a blood sugar spike with a certain type of bread, whereas that same type of bread may not spike a blood sugar of a different person the same. So, you know, it's all about sort of going towards that personalised medicine, personalised nutrition is hopefully the way forward. But yet you have to think about the individual, not just like everybody as a whole.
So, main point to take away from your diet with regards to type 2 diabetes intervention?
So I would say that aiming for more plant-based foods, fresh foods, even if it's fresh frozen, like that's completely fine. So you don't have to be going out and buying fresh fruit and vegetables all of the time. Even tinned fruit. So like if you know, try and find ones that are not got any added sugar in, but maybe just in some like brine or something like that, then, you know, even that's fine. So it doesn't have to be expensive. Increasing the amount of pulses, like you say, beans, lentils, things like that, into your diet. Trying to eat the rainbow as well. So eating more colourful foods. Trying to reduce the amount of animal fats that you're having. So that does include eating, you know, animal protein. You can eat animal protein, but just try and restrict the amount you're having. And maybe just go for leaner meats. So things like chicken, or turkey, things like that. Also then incorporating good fats into your diet as well. So things like extra virgin olive oil to, you know, cook with, or avocados, they're really good. Nuts and seeds. We now every morning will have sourdough, which is good for your glycemic index. But also we'll like put maybe some eggs on it. We don't have eggs every day, and then some avocado, and then over every breakfast we'll put like a mixed nuts and seeds, which you can just buy from the supermarket.
Yeah, that's fine.
And it's such an easy way to get more fibre into your diet. But yeah, I think it's just about, you know, small steps and like doing what's right for you. But definitely just trying to incorporate more fibre, more plant-based foods and more colourful foods.
And then we can look at energy restriction as well at the same time. Try and eat less, especially at the beginning, eat less than what you actually need to.
Yeah, and
don't overeat.
I think as well, you know, as part of this increasing your plants and increasing your fibre, it will feed your gut microbiome. So they're involved in all the processes that regulate hunger. So you may find that if you do increase the amount of fibre that you're eating in your diet, you may not feel as hungry. So even like switching from white bread to brown bread, it takes longer for your body to actually digest it. So you feel fuller for longer. And then using things like oats. So there's a lot, and I think if you go onto the Diabetes UK website or even the Zoe website, there's so many good hints and tips on there. So we'll leave the links in the description box below, because I found it really useful when we researched this podcast.
Yeah, they were. Before we go on to exercise, artificial sweeteners, we said we'd include them.
Yeah.
They differ from country to country. So America do use different ones to us. For example, the evidence at the very beginning is that it gives you the same sensation of sweetness, but it doesn't be absorbed, so you don't have the energy intake, you don't have the sugar intake, and it should be inert and come straight out. Recent evidence has shown that it actually might interfere with your microbiome, and also it can lead in some studies to insulin being increased regardless of, despite the fact there's no sugar within the diet. And I mean, in terms of your dental caries, that's why a lot of people do prefer them as well. It is better for your teeth. There has actually been studies for that. But in terms of what would you do, my advice is if you can stay away from carbonated drinks, try and stay away from them. Water's
going to be the best bet for any drink that you're going to have ever. So, you know, if you can do, it's worth just maybe even cutting down if you haven't sugary drinks, because like you were just saying, then America, they have slightly different laws. So there was a high corn syrup fructose, was it? Is that how you say it?
Yeah.
Like that's been linked to actually accumulation of fat in your liver. So, which we know, like we said in the last podcast, increases the risk of insulin resistance. So there are more studies that need to be done, but it looks like they do increase your risk of a lot of different long-term health conditions, and especially type 2 diabetes.
Yeah, and also they are included in a lot of foods that you actually may not know they're included in. So we just think of artificial sweeteners within diet beverages and sweets, etc., but they are used in other packaged foods, and it's just to be wary of them, and that they are not as saint-like as what everyone used to think they are.
Yeah.
And until more evidence comes out, I couldn't really advise on it, but I'd just be more mindful. And if you can, try and go for something that isn't sweet. Go for something that's more natural. Go for a water. I know it sounds boring, but
I love water.
you do, and I've gone more towards it. I mean, I've never had fizzy drinks really. I stopped them at 17, 18, but
even putting like some lemon or some lime in your water, or like it just makes it a little bit. You actually can get them capsules now, can't you, which they call like up, so you put it's like a scent, so obviously your scent and your taste are all involved in like the same mechanism, so when you drink the water it's supposed to make it taste like you're drinking. I think they have like a Coke flavoured one and things like that, so there's a lot of things out there now that you can do, but
there is
always try and go for water because it's going to be good for your skin as well as everything else.
Exercise, we'll just touch upon this. Like with any healthy lifestyle, it's good to exercise. Resistance train, balance, cardiovascular training. Try and incorporate them all, not just for the acute phase, for longevity in terms of it reduces fall risks in the future. Strength and bone density, etc., will continue to increase despite a lack of hormones. I think there's a study on once you've eaten, postprandial glucose will actually reduce if you take a nice walk, or I think even fidgeting. Like literally just bobbing your leg up and down for 20, 30 minutes. You do. I don't tend to do that, but if you take a walk, it is more beneficial for you than what you think.
And also specifically for type 2 diabetes, if you do exercise, if you build muscle, your muscles are able to absorb glucose without the need for insulin, so it would lower your blood sugars.
I think that's if you intensely exercise. And then when you actually look into how sugar's used within the body, so intensity, it's more from the glycogen in the muscle. If it's low intensity, it will be from your blood supply. It goes into another complex level, which
we're not going to
I don't want to go into.
Exercise is very beneficial for
I need to look into it a bit more as well, to be honest.
Okay, so I feel like diet, exercise, is there anything? I think stress management, that's another one that we haven't really discussed, but it's like we discussed in the stress podcast, it can increase the amount of inflammation in your body. There is inflammation going on when you've got type 2 diabetes, so just trying to manage that. It
will also increase your blood sugar. So in signs of infection and stress, it will go up.
Of course. Also sleep as well. The studies that show that if you get less sleep, you're then more hungry the next day. You're more hungry the next day, the more calories you tend to consume, so that will increase your risk of developing, obesity, being overweight, and then subsequently type 2 diabetes. So there's a lot of things to bear in mind, but
we wanted to focus on the non-pharmacological factors and how important they are, and them in their own right can actually prevent type 2 diabetes and treat it better than a lot of the medication that we've actually got. Now, we did touch upon HbA1c at the very beginning, so we will go through the targets again. So 48 is classed as a diagnosis of diabetes. So if you are using diet and lifestyle and drugs that don't cause hypoglycemia, so that's metformin, you can class gliptins in there, so your sitagliptin, etc. They will have the same target of 48. Now, drugs that do cause hypoglycemia, so your insulins, your glycosides, sulfonylureas, for example, they will have a target of 53. And then these are standard, by the way. I'm going to touch upon something else. And then if it does increase to give or take 58, 59 region, then you would think about intensifying treatment. But as with anything in medicine, it's individualized. A lower HbA1c for someone could have severe consequences. So if you are a HGV driver, for example, if you're elderly, if you've got a long-term health condition, cancer, for example, and you've not got left to live, what's the benefit of having this tight control? Because it could lead to falls, induced into comas, etc. So you would relax it in them patients. And that's one thing I wanted to get across. They're standards that are set, but you need to take the patient as an individual.
Like we said, with diet as well, it's always trying to treat the individual rather than like the whole group of patients.
So if you were diagnosed, diet and lifestyle, which sadly is the problem, it's not taken as serious as we would like it to be. It leads to medication or the need for it. What's the first line?
So first line for type 2 diabetes is always metformin. It's good in terms of there's a lot of studies on it. It doesn't cause hypoglycemia, so there's no risk associated with that. It's also good for weight loss as well, so it does help with weight loss, or it's at least weight neutral, isn't it? So that's always the first line. With metformin, a lot of patients will find that they do get GI side effects, so that could be things like nausea, vomiting, diarrhea, and unfortunately that is just they're just quite common side effects of it. However, if you do experience that, then we would then switch a patient to the MR version, which is the slow release, because that can mitigate any of them side effects.
Yeah, the reason being it just stops the concentration going too high, doesn't it?
Yeah.
Now, metformin ideally is first line because it's got the cardiovascular side effect, benefits, I mean.
Yeah.
Now, recent changes in guidance over the last couple of years, would you say?
Yeah.
So a lot of patients will know these and they will struggle to say them. They are the gliflozins. I nearly struggle then. Main one being dapagliflozin.
Yeah.
And if a patient's got established cardiovascular disease or they have heart failure, we would then offer this in addition to metformin.
Mm-hmm.
If they've got a high risk of cardiovascular disease, such as people might be familiar with the Q risk score, if that's above 10%, they've got high blood pressure, dyslipidemia, a few other factors, we would then consider putting this in. And the benefit is that it's shown to, improve your cardiovascular health through multiple mechanisms. They are also beneficial in the kidneys and they have a lot of benefits. But as with all medication, they do come with side effects, which we will touch upon later.
Yeah. Then after that, so you can then go into triple therapy, can't you? So you can add in other anti-diabetic drugs. So there's a few. So there's pioglitazone, then there's the DPP4s, so things like sitagliptin, linagliptin, and then you've got the sulfonylureas, which is things like glyclazide. And then after that, if that's not suitable, then is usually we would refer to like a diabetes clinic if the HbA1c isn't coming down, and then it could be things like adding in insulin. We used to be able to add in the GLP-1s, which they're the medications that are in the news all of the time at the moment, like the weight loss drug. But due to the worldwide shortage at the moment, we're not able to start anybody on them.
On the injectables now.
Yeah. But I think that may change because I think tirzepatide is a new medication in that class, and there is no national shortage or worldwide shortage of that at the moment.
At the minute, but
so it may change.
It may increasing.
Not. Yeah.
So if you are watching a YouTube video, it will just display the logo because when we've been editing it on Sunday night, we've recognised that the camera just sort of stopped recording, didn't it?
Yeah. Rather annoyingly, me and technology have never really got on. But yeah, so we're going to try and just pick up where we left off. It is quite difficult because we were in sort of a flow of actually speaking about medication, weren't we? But we'll give it our best shot and see how it goes.
We're not doing a video recording because we're now in pyjamas.
Yeah.
Basically, it's Sunday night.
Sunday night. So yeah, we're just going to do it by a voice note. So anyone listening to it on Spotify will, it won't be any different for you guys. But you may, notice that. Well, obviously now you will because this will be in it. But the conversation may not flow.
As good, yeah.
That's good.
I mean, I think I got up to the point that diabetic therapy now is individualised. So years ago it was metformin. You used to go to a sulfonylurea, which was a glyclazide, and then you'd go to insulin, etc. But now we do metformin. We try and add in the other medication depending on your cardiovascular risk, and then we look at your lifestyle as an individual. Now, I've said before, and I've just looked at the example that I give, was a HGV driver.
Yeah.
We wouldn't give them a glyclazide as the next line therapy, ideally, because it leads to increased blood glucose monitoring, hypo risk, etc. So we look at the patient individually, and we went over the treatment guidelines and algorithms, and now it was just to touch upon things that we look at when we prescribe the medication, things that patients should look at when they are on medication in terms of what monitoring they should go through.
Yeah.
So metformin being the first one.
Yeah, so metformin, like we say, first line drug, but as with any medication, these medications come with side effects or potential risks. So with metformin, you have to look out for renal function. So it's actually contraindicated at anything less than 30 mils a minute, which is important because, like we said in the last podcast, CKD, chronic kidney disease, is a real issue or risk with people who have type 2 diabetes. So just to be just look out for that. If you do experience maybe increased side effects from metformin, it might be that your renal function's gone off a bit. It might be that your renal function's deteriorated. So it might just be a case of going and getting your bloods done. It can also cause low B12, so that's a vitamin that is essential in your body. So really and ideally we should be checking B12 levels. That's just done by a blood test. Admittedly, I do tend to miss this one out, so it's definitely something that going forward I'm going to try to incorporate into my practice. And then the last one is lactic acidosis. Again, just to do with your renal function, and
when you've got low oxygen as well, so after heart attacks, etc., or
yeah.
liver disease, all these things, alcohol, intoxication, they can all lead to it. One thing that I pick up a lot on is after heart attacks, a lot of people don't get stopped on metformin, and in that first few days, definitely they should have it held, because of the risk of hypoxia and all them things. Yeah.
And then the next class of medications are the SGLT2s, so things like canagliflozin, dapagliflozin. So these have quite a few warnings. So it comes from a group called the MHRA, which is like the Medicines Regulatory Organisation. It's run by the government, isn't it? And they will come out with warnings for all different types of medications that we need to make our patients aware of. So like I say, the SGLT2s do come with a few. Potentially because they're quite they're newer in terms of the anti-diabetic drugs, so monitoring for those medications in terms of reporting on side effects is heightened within like the first couple of years when they come out. So that's a potential reason that people may be recording more frequently because of this. It's called, what's it called? Is it like a black triangle, isn't it?
The black triangle, yeah.
Yeah. So do you want to say what some of the risks are for them?
I mean, the way it works is it stops glucose from being reabsorbed from your kidney. So that leads to increased urine output, leads to increased salt output. So that's why it's beneficial, because it lowers your blood pressure and can lead to cardiovascular benefits that way. But with having increased urine output and sugar in your urine, you can increase urine infections. There is a very rare risk of Fournier's gangrene. There is also lower limb amputations.
Yeah. Also euglycemic DKA, which is a medical emergency, which is where your blood sugars are just running extremely high, and then your body is using or is producing ketone bodies, which are, toxic. They produce they cause your blood to go acidic, which then can denature enzymes, and it leads to a whole host of problems. So like we say, it's something that you would have to go to hospital for. The euglycemic part of it is that actually when you do test your blood sugars, they may not be high. So usually in DKA, your blood sugars will be high, but in this type of one, they're not. With the SGLT2s, we try and advocate for patients to monitor the ketones during acute illness. So we also have sick day rules as well, which means that if you are acutely unwell with an infection, or you've had maybe some food poisoning, you've vomited, you've got diarrhea, it obviously can affect the amount of food that you're eating, so it'll affect your blood sugars. So we say sometimes for patients, if they are acutely unwell, to hold these medications. Like Lee said, they also go through your kidney and they can cause like electrolyte imbalances. So it could worsen that if you are already ill and then taking those medications. So it's just something to be aware of.
Yeah, and when they first come out, we weren't able to start them in low kidney function. But now they are used for deteriorating kidney function and in a different cohort of patients. But in terms of the diabetic benefits, if your kidney function goes below 45, we don't start it because it doesn't really have the beneficial effect on the blood glucose lowering.
Yeah. The next group are the sulfonylureas, so things like glazed. The main one for them is, like Lee said before, they can cause low blood sugars, so hypoglycemia. With those medications and that class of drugs, you should be testing your blood sugars. A lot of patients you do see are not actually, and so that's something that I will tend to do if I'm doing a medication review on a patient and they're on glazed and there's no monitoring strips. I will make sure that they are checking, because like I say, some patients aren't. A lot of patients nowadays do say that they tend to know when they're having like low blood sugar, so that's why they don't test. But obviously you may not always be able to detect low blood sugar.
Well, like we said in the last Yeah, like we said in the last podcast, autonomic neuropathy
Yeah.
can lead to sort of a misalignment of what your blood sugar is.
Yeah. And for the reason, like you say, with the low blood sugars, we try and stay away from those in elderly patients, don't we?
We do.
We do use them still, but you know, there are other agents that we would prefer to use over them. Then the DPP4s, so things like sitagliptin, linagliptin. The main one for them is pancreatitis. I can't think of any other ones that stand out to me.
I looked a bit more into it before, and they can cause hypoglycemia, but only when used in conjunction with insulin, etc. But normally they're not that potent in comparison to the other anti-diabetic drugs, and they are a good midline agent, really.
Yeah, so
they're not offensive.
Yeah, pancreatitis would be like a severe pain in your stomach. You could get nausea and vomiting with it as well. Again, it's a medical emergency, but it's easily treatable in hospital, and usually once you take away the offending agent, which in this case could potentially be the DPP4, you know, it should resolve.
Yeah, and one thing to touch upon, kidney function does matter with a couple of them.
Yes.
So sitagliptin being the main one,
yeah,
it is cleared mainly through the kidney, and a lot of the threshold's quite high.
Yeah,
so a lot of patients actually do qualify for a dose reduction, and it's normally missed by a lot of clinicians.
Yeah, I think it is. Linagliptin's
that's the best one because you can have it in,
isn't it? So
yeah,
that
so it
doesn't affect. So you do tend to see a lot of diabetic patients with CKD on that one, because like you say, basically if with all of these medications, if they are renally cleared and your renal function isn't high enough for these medications, it just increases your risk of developing side effects, which we don't want, isn't it?
It is, and sometimes in some cases as well, they're not studied in that cohort, so then you can't safely say what's going to happen.
Yeah. Then pioglitazone, so I always remember this one as being contraindicated in heart failure.
You've got bladder cancer. Well, the heart failure is because it leads to an accumulation of fluid.
Yeah, so, you know, heart failure, you do get an accumulation of fluid anyway within that condition, so we don't want to worsen that anymore. And then, like you say, risk of bladder cancer. I did read in the BNF that it did say, though, if you did have a history of bladder cancer, then if there was no other agents that would be suitable for you, they can use pioglitazone. It would just be a risk-benefit thing. And usually, if you've got a history of cancer, you're probably going to be under surveillance. So that potentially could be why they would still use it. But again, just something to be aware of, that it can increase your risk of that.
It's actually quite a good drug as well. I actually looked into it a bit more, and I think it's got like a 30% effect of lowering your blood glucose, which is quite high, really. Yeah. But again, it's the only medication of its class that we still use. I'm not going to name the class because it is a tongue twister. It's the thiazolidinediones, I think, glitazones, but yeah, you've got heart failure, bladder cancer, osteoporosis.
Oh yeah, I always miss that one out. Yeah.
Yeah, but again, they're not normally used in practice. If they are, they're normally under a diabetic clinic at this point anyway.
They're not, you don't really tend to see them that often. But again, I don't know why, in terms of with the fact that it is so potent in reducing your blood sugars. I wonder why. I think it used to be that they couldn't really be used in combination with a lot of anti-diabetic drugs. Was that springs to mind? But whether that,
I know before we qualified, a lot of the medications had different licensing and what they could be used in, so you couldn't have triple therapy with certain brands and certain components of medication, and it was a nightmare.
I feel like that was one of them, and that may be why. Okay, then we go on to insulin. Again, obviously the nature of using insulin, it can cause low blood sugars.
Yeah, it's invasive.
Yeah.
It can cause lipid dystrophy, which is basically abnormal, like fat. I can't even think of what it is. It's just basically like a skin disorder, essentially, where it's affecting the fat composition within the area where you're injecting, so you're meant to rotate the sites.
Yeah, I think also with that, it can affect absorption of the drug as well. So it may be more painful because you've used the site like quite frequently. But again, like I say, it can change the composition of like the fat under your skin, which can affect absorption. So that's why we say to rotate it. Also, if you think about insulin, some patients may be on like a basal bolus regime, which means that they could be injecting themselves up to 4 times a day. So, like you say, it is quite invasive. You have to monitor your blood sugars when you're on insulin. Things like driving as well, like you were saying with the with the sulfonylurea, it's the same thing. I don't know whether the DVLA will need to know that you're taking them medications, probably.
They will, yeah.
Yeah.
And it'll affect your insurance greatly.
Yeah. And then it can cause weight gain, can't it, insulin? Just like obviously the way it works.
Pardon me.
And then the last
GLP-1s.
one, yeah, GLP-1s, so they're the skinny pen. That's like how a lot of people know them today, but pancreatitis is the main one that we would always counsel patients on, isn't it?
That's the main one. I mean, there's loads of other things that they do cause, and there's a lot of cohorts that they've not been studied in. It can lead to other side effects like tachycardia, raised heart rate. That hasn't been used as such in patients with bowel problems because of how it works
like
as well.
And things like that.
But when they come out, they were revolutionary because they alter your weight by working on, like we said in the previous podcasts, on the neurons within the brain, and then they have the diabetic glucose lowering effect. So it was 2 birds, 1 stone. But as we know, they've been misused in a lot of patient cohorts. They've been overused, and it's led to a shortage, which every time we look on the websites, they keep getting pushed back. So we can't start anyone unless it is of absolute need and we have got a supply chain in place.
Yeah, they're so easily accessible these days. I know I've heard of people, young girls with a BMI of maybe like 25 buying them, because I'm going on holiday, and it's so easy to just get that over the, from an online pharmacy. So it's quite scary because, they are still, I think they're still Black Triangle medications, aren't they? So which means that they're still, they're still.
I don't know whether it's 5 years, is it, the Black Triangle?
Is it? Maybe maybe it's tirzepatide then, that's just got it in that at the moment. But, it still means that there's still a lot to learn about these medications. When you give a medication or anything to a mass of people, there is going to be more and more side effects that come out. So in years to come, there could be things that we didn't know from initial trials, because it obviously was a smaller cohort of patients. So it's just to be wary that if you don't need the medications, think twice about using them.
And people don't understand or maybe don't realise that when they do trials, it is of select cohort of patients. It might be diabetic patients, certain BMIs, certain other comorbidities. It's not normally on healthy BMI people in this instance with no diabetes. So you don't know how the drug's going to interact.
Yeah.
It could be detrimental.
Yeah.
All for what? Just the physical appearance.
Yeah.
And not true health. But
yeah.
It was quite hard actually doing this podcast after leaving it for the weekend, coming to editing it.
We've had a lovely weekend, haven't we, as well, which I think we will do a podcast on because we went on a little sort of retreat, wellness, health and wellbeing retreat. So coming home tonight, we're a bit tired and obviously come to edit the podcast and then realise that it cut off. But I think that's probably just a sign for us to maybe invest in a good camera or more storage on our phones. But no, as always, thank you for listening to the podcast. We hope that you've enjoyed it. If there's anything that you would like us to discuss in future podcasts, then please let us know. And also, if you have any questions about this podcast or any other podcast that we've done, then just drop us a message.
Yeah, and I don't know whether we mentioned it before it got cut off or not, but again, this podcast is advice. It's all of our own opinion. It's no substitute to seeing a healthcare professional, and you should always seek medical attention if that applies to you. But yeah, like Jess said, thanks for listening, and we've got quite a few more in the pipeline. So see you soon.